There's several cases that have been previously diagnosed with thalassemia. They have enlarged size of the placenta, and when they're born, most of them has very severe anemia at birth. Some of the patients require phototherapy. Some of them even require immediate blood transfusion after birth. Most of the patients that we have identified usually being diagnosed at the beginning of their life as having what we call neonatal infection or congenital infection by the virus or a bacteria. However, all of these cases, we could not really identify the causes as the pathogen or bug that causing this condition. This is the beginning of the research that leading to the discovery that indeed this family, they have the mutation in another gene, which is, we call it as the KRF1 or erythroid Krüppel-like factor. And this is the KRF1 actually is the master of the transcription regulator within the red cell development. So when you have the mutation of the KRF1, even though you don't have any mutation in the globin gene or the PK gene, which is downstream from the KRF1, but you have the effect of the down regulation and down reduction of the expression of these two genes, similar that like you have the mutation in the globin gene itself. I would say 80% of the patients with KRF1, they require regular blood transfusion every 2 to 3 weeks in order to survive. And of course, they will need the iron chelation therapy. I will provide them with all the supplementation, folic acid, the multivitamin, and of course, the antioxidant therapy. I would say at present, around 30% of the patients, they respond to such a treatment, so they can maintain the level of hemoglobin. However, the rest of the patients who are more severe, we have two options. One is to keep them with the regular blood transfusion and of course the iron chelation therapy, and the other mean that we can do is to perform the splenectomy. However, the clinical response to splenectomy can be quite variable as well, and we need to inform that to the patient for the further decision that has to be done together between clinician and also the family. We found it to be quite common. At least around 0.5% of the Thai population are carrier of this mutation. So there is a possibility that these, two carrier who are not related, they can come together, fall in love and getting married. So, we probably have more and more cases. So at present, in order to prevent this condition, we have two measures. One measure is the prenatal diagnosis. Another measure that we can do is the pre-implantation genetic diagnosis, meaning that instead of having baby in a natural way, we will ask them to have a baby through the IVF technology or in vitro fertilization. We already designed probe, primer, and the sequencing technology to identify such a condition. Now we have board technology to prevent such a condition for Thailand. The study has impacts in several aspects. So the first aspect is in terms of the biology, in terms of the medical science. This is the first condition in man that when you have the mutation of this gene, you have persistent expression of embryonic globin. We show that in our patients, they have embryonic globin such as hemoglobin Portland, hemoglobin GAL1, and hemoglobin GAL2. And these embryonic globin are persistent even in adult life. It have never been found before. The other impact is the impact in terms of our clinical practice. When they know what the condition that they have, that can lead to a correct diagnosis, we can manage them more properly, more appropriately. We can even do the prevention and control if they want to have another children. Then we can avoid the chance that they get another children with the affected diseases. And of course, we are doing some kind of, a prevention and control at a national level. In the very near future, this information will be crucial, is indispensable for the future policy that should we screen for this condition for all of the pregnant women in our country.